All right, so this is part 4 of our neurology review questions, the final part. So question 19, we have a 72-year-old woman brought to your clinic by her daughter. The daughter says that over the past several months, her mother has become less sharp and was alarmed yesterday when she forgot her granddaughter's name. On asking, the patient says that the month is May, and it's actually July, and that we're in Chicago, but we're in a suburb of Minneapolis. Which of the following medications would be most beneficial to this patient? A. Bromocriptine, B. Mirtazapine, C. Rivastigmine, D. Rapinirole, or E. Pramipexole? Okay, and the answer to this question is C. Rivastigmine. So this is a patient who has Alzheimer's disease. And we know that she has Alzheimer's disease because, one, we're not told of any depressive symptoms. Depressive symptoms would make us think possibly of a pseudodementia. Two, we're not told of any other physical abnormalities. And three, she has dementia. We know she has dementia because she's unaware of time, she's unaware of place, and those are big indicators of dementia. So because she more than likely has Alzheimer's disease, we are going to give her rivastigmine. A, D, and E are all drugs used in Parkinson's disease. They have no place in treating dementia. Mirtazapine is an antidepressant, which would be a fine choice to use if she had pseudodementia, or we are suspecting pseudodementia. So remember, with all our different kinds of dementias, Alzheimer's is sort of our diagnosis of exclusion, which you should, on the USMLE, presume that the dementia is if they're not telling you any other kind of symptoms, especially movement symptoms, and this isn't something that is occurring with focal deficits or that it's getting suddenly worse. So Alzheimer's should be your go-to, even though it's a diagnosis of exclusion, just because it's the most common overall. If you have a patient that's got focal deficits and has a lot of risk factors for stroke, then you can go towards vascular dementia, in which case you'd treat it like any other kind of stroke, and you get a CT. There's lots of other kinds of dementia which can occur, particularly with some of the movement disorders like Parkinson's disease, Wilson's disease, Creutzfeldt-Jakob disease, Huntington's disease. Those are all going to be accompanied with your typical symptoms that are typical of those diseases. So Wilson's disease, remember, is a disease of the liver, and so you can have a lot of liver symptoms. You're also going to have Kaiser-Fleischer rings, etc., etc. HIV-related dementia. These patients tend to be HIV positive. You might see opportunistic infections. Creutzfeldt-Jakob disease is a sudden dementia. It's not something that comes on. Over a long period of time. It's also extremely rare. Huntington's disease is autosomal dominant, so there tends to be a rich family history of it. Frontotemporal dementia, usually the shining feature of frontotemporal dementia is the severe personality changes. And then Parkinson's versus Lewy body dementia can be difficult to distinguish between the two. Usually with Lewy body dementia, the personality changes precede the movement disorders, the dementia and the personality changes tend to precede the movement disorder, whereas Parkinson's disease, the movement disorder, tends to precede the dementia and the personality changes, if there are any. Okay, so that's just a sort of quick review. I did an hour-long review on dementia, so make sure and watch that if you're unclear about any of this. Okay, question 20. A 51-year-old man is brought to the ED by his wife, who is concerned about his recent forgetfulness. Yesterday, he became lost on his way home from work. He's presently disoriented to place, but not to person or time. Past medical history includes a recent diagnosis of Parkinson's disease, in which the symptoms began 2 months ago. Physical exam are consistent with a diagnosis of Parkinson's, as you note, a pill-rolling tremor and masked facies. Which of the following is the most likely diagnosis in this patient? A. Parkinson's dementia, B. Alzheimer's dementia, C. Mixed dementia, D. Lewy body dementia, or E. Creutzfeldt-Jakob disease. Okay. The answer here is Lewy body dementia. Now this can be a difficult call, and I realize that maybe I should have phrased this question a little differently. However, the way that you will generally differentiate Parkinson's dementia and Lewy body dementia is that Parkinson's dementia, the patient will have an extensive history of Parkinson's disease, and the dementia tends to occur in the end stages of their Parkinson's disease. Whereas with Lewy body dementia, the diagnosis of Parkinson's is around the same time when they develop their dementia. So in that review earlier, I kind of said that dementia comes after the movement disorder. With Parkinson's, with Lewy body dementia comes before or with movement disorder. That's not necessarily always how it is. What I would look for is with Parkinson's dementia, the dementia occurs usually in the late stage of their Parkinson's disease, whereas with Lewy body dementia, it's right around, maybe a little before, maybe a little after the development of their movement symptoms. This is a difficult thing to differentiate the two, and pathologically they're very similar, but if you remember it kind of like the way I told you, you should be able to get any quality right. It's not common for them to make you differentiate between Parkinson's dementia and Lewy body dementia, but that's the way I told you is a pretty good way to decide between the two. Okay, that's just the same thing. Okay, 21. Okay, this is the same patient. We've diagnosed him with Lewy body dementia. While in the ED, patient becomes agitated and psychotic, accusing physicians of being part of an extraterrestrial scheme to plant cameras in his thoughts. He becomes physically aggressive towards staff. Which of the following is the most appropriate agent for this incident, for this patient, I should say? God, I've been working a little too long now. You're addressing the patient, you're not addressing the incident. Okay, is it A, haloperidol, B, ziprasidone, C, olanzapine, D, chlorpromazine, or E, quetiapine? Probably remember from just a little bit ago. The answer is E, quetiapine. So quetiapine or risperidone are the preferred drugs for patients with movement disorders. And Lewy body dementia does involve a movement disorder. So we would prefer to use quetiapine or risperidone. Haloperidol and chlorpromazine are your first-generation antipsychotics. They're definitely not preferred. Ziprasidone and olanzapine would be a little bit more preferred, but not so much as quetiapine and risperidone. So, risperidone and quetiapine are the best antipsychotics in patients with movement disorders. And unfortunately, patients with movement disorders, as I alluded to earlier, often get psychotic symptoms just for the fact that we may overtreat them. Okay, question 22. A 26-year-old medical student presents to your clinic complaining of difficulty on his surgery rotation. He says that his residents and attendings have made rude and uncharitable remarks about his performance during suturing. On physical, you note fine tremor of his hands and wrists bilaterally, but no other neurologic deficits. He does not consume caffeine and is on no medications. His vitals are within normal limits. Which of the following will most likely benefit this patient's neurologic condition? A, carbidopa-levodopa, B, propranolol, C, clonazepam, D, gabapentin, or E, clonidine. All right, so medical student running into some rude staff. He's got a tremor. Okay, the answer here is B, propranolol. So this guy has an essential tremor. And an essential tremor is very common. Essential tremor, it's almost not a disorder because it's so common, but it is a movement disorder, and it's the most common movement disorder, and it is incredibly problematic if you have any kind of job, like if you're a technician or you're a jeweler or if you want to be a surgeon. It can be a big problem. And so treating it is definitely indicated, and the drug we go to is propranolol. So we definitely aren't going to use carbidopa-levodopa. That's for Parkinson's disease. Clonazepam, gabapentin, and clonidine may be used, but they're second-line agents. So propranolol is the drug of choice in the treatment of essential tremor. Primidone is another drug that can be used, especially if beta blockers are contraindicated, so if the patient has asthma. There are other drugs that are second line. Then there's electrostimulation has been used, and last line would be like surgical therapies for really refractory cases. But propranolol is the drug of choice for essential tremor, which is what this medical student has. Question 23. A 41-year-old woman is brought to the ED by her husband. She is presently having delusions that he and the neighbors are trying to kill her and their children, and she has become very defensive. These problems have been on and off for the last several years, and it's generally controlled on quetiapine. On physical exam, you notice mild hand tremor as well as slurred speech, which her husband says has been getting worse over the past several months. Labs revealed elevated transaminases. Which of the following is the best next step in the management of this patient? A. Serum ceruloplasmin level. B. Slit lamp examination. C. Lumbar puncture. D. Brain MRI. Or E. Admission to the psychiatric unit. All right, 23. The answer to this is B. Slit lamp examination. What are we concerned about in this woman? She's got for several years, she's been having delusions, paranoid delusions, may or may not have been diagnosed with schizophrenia. Probably she has because she's on an antipsychotic. However, she's also got some movement issues, which may be an adverse effect of her quetiapine, but she's got elevated transaminases, and anytime we see neuropsychiatric symptoms, particularly psychosis, with liver abnormalities, we are concerned about Wilson's disease. So for Wilson's disease, we can make the diagnosis if we see Kaiser-Fleischer rings on physical exam. We don't see that in this patient. And in some patients, you won't notice Kaiser-Fleischer ring. And not having a Kaiser-Fleischer ring does not mean that the patient does not have Wilson's disease. They may have a Kaiser-Fleischer ring, but it's hard to note with the naked eye. So the first thing to do in a patient that has suspicious Wilson's disease but no Kaiser-Fleischer ring is to get a slit lamp examination. A slit lamp examination, if it shows Kaiser-Fleischer ring, then you would diagnose Wilson's disease and go ahead and treat. If the slit lamp examination comes back negative, you can get the serum ceruloplasmin levels. If that comes back positive, again, you're going to treat for Wilson's disease. And the ceruloplasmin levels would be low. Remember, the ceruloplasmin is something that holds on to copper. So if you don't have anything to hold on to copper, copper is going to get into your tissue. And when copper gets into your liver tissue, it causes cirrhosis. And when it gets into your brain tissue, it causes movement disorders and psychosis. I didn't intend to rhyme there. Admission to a psychiatric unit may be appropriate for this patient. However, we really need to rule out Wilson's disorder first. And I don't know if it's really necessarily problematic because she doesn't appear to be a threat to herself or others. Anyway, that's an aside. Okay, so Wilson's disease, as I mentioned, Kaiser-Fleischer rings plus neuropsychiatric symptoms, and that makes a strong clinical diagnosis and means you should definitely be starting therapy as the next step in management. However, if you don't see any Kaiser-Fleischer rings, then the best initial test is going to be a slit lamp examination, and in that case, the ophthalmologist may be able to note the Kaiser-Fleischer ring. If the patient doesn't have a Kaiser-Fleischer ring on the slit lamp examination, then you can get a ceruloplasmin level, and the ceruloplasmin level, if it's low, would be enough to treat for Wilson's disease. Ultimately, the gold standard diagnosis, the gold standard test is going to be a liver biopsy, in which case you would see the actual copper in the liver tissue, as well as cirrhosis. Okay. Question 24. So you've got the same patient, you've done a slit lamp examination, and it shows bilateral Kaiser-Fleischer rings, as you probably suspected. Which of the following is the next best step in the management of this patient? A, D-penicillamine chelation therapy, B, serum ceruloplasmin levels, C, urine copper levels, D, deferoxamine chelation therapy, or E, dimercaprol chelation therapy. So, she's been diagnosed with Wilson's disease. What do we do next? And the answer to this question is D-penicillamine chelation therapy. So the Kaiser-Fleischer rings is enough to diagnose Wilson's disease. At that point, you don't need to get ceruloplasmin levels. You don't need to get urine copper levels. At that point, we're going to start treating her. And D-penicillamine is what we use to chelate out copper. Deferoxamine is also used for chelation therapy, but that's used to chelate out iron. So, and then dimercaprol is used to chelate out lead. So ceruloplasmin levels, as I mentioned, are not necessary. The urine copper levels are not necessary as well because we already know she's got Wilson's disease. However, you can use urine copper levels, and they are used to monitor the response to the chelation therapy. So the urine copper level should decline. Okay, and then just put here that the treatment of choice is penicillamine, and also the patient should be advised to follow a low copper diet, weekly follow-up for 6 weeks, and then, God, these spelling errors. I am so sorry. Frequent follow-up thereafter. Patient will often need lifelong chelation. Actually, they will need lifelong chelation. And then you should refer her out to hepatology so they can do some diagnostics in case there's any complications. Okay, question 25. Last question. A 29-year-old male presents to your clinic complaining of depressed mood. He says that recently he has not had much energy and has not slept well. His appetite is less, and he's had feelings of guilt for various decisions in his past. His mother says that his personality seems different lately, and he has become less concerned about the organization of his room. So he's turning into a slob. And he doesn't shower as much as he used to. She is also concerned because there are a lot of members of his estranged father's family who committed suicide and, quote, went crazy at a young age. Physical exam is significant for an unusual rhythmic-like movement when he walks. Otherwise, it's unremarkable. Which of the following is the best next step in the management for this patient? A. Prescribe venlafaxine for major depressive disorder. B. Slit lamp examination. C. Serum ceruloplasmin level. D. Chromosome analysis. Or E. Head CT. All right. And the answer to this question is D, chromosome analysis. This guy is very, 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 very suspicious for Huntington's disorder. Why? Because he is having abrupt personality changes, because he has a family history of psychiatric issues, which of course is common in a lot of people, but in this case it's really significant. They went crazy at a young age, supposedly, and a lot of them committed suicide, and both of those are consistent with Huntington's disease. And then the physical examination, and this is the most important part, is characteristic for chorea. And chorea is this sort of dance during movement, and remember, it comes from the Greek word chorea, and it's the same place where we get the word choreography or choreographer, and that means like somebody who writes a dance. So it does mean dance. And Huntington's disease used to be called Huntington's chorea. So the best test for Huntington's disease is a chromosome analysis. It's definitive. A head CT might give you hints, but really the head CT only will really be, it's never definitive for Huntington's. You're going to always have to get the chromosome analysis, and it really only can tell you the difference in real progressed Huntington's. So that I do want to show you, though, because with Huntington's, you do get a degradation, and this is the pathologic problem behind it. You get a degradation of the caudate. And the caudate is right next to the lateral ventricles. And so if you get a degradation of the caudate, the lateral ventricles are going to increase in size, and so you can see a little bit of differences on the head CT. But that varies, and you're always going to have to get a chromosome analysis to put the official stamp of Huntington's disease on the patient. Okay, so physical exam for Huntington's disease, as mentioned, most notably and most obviously, it's going to be chorea, but that's not in all patients. Huntington's disease, when it first starts out, may just be the personality changes, the mood changes, but then the chorea and the movement symptoms start developing later on. The chorea can be integrated into purposeful movements, so they may be walking to get a cup and they're kind of doing this little dance. You can also see bulismus, which is just a rapid flailing of an extremity. And then also athetosis. And a lot of times you see the word chorea and athetosis put into one word, choreathetosis. And the athetosis is unlike chorea, is not part of purposeful movement. It's just sort of this purposeless sinusoid movement of the hands or of the arms. And it's just kind of there. If you want to, I can't really describe it, so if you really want to look it up, like I say, look on YouTube. You can see plenty of patients with Huntington's disease. They can also have some Parkinsonian symptoms, such as bradykinesia, postural instability, rigidity, akinesia, and so forth. So diagnosis for Huntington's disease, as mentioned, you can suspect it on clinical grounds. However, in order to make the official diagnosis, the initial and most accurate test is going to be genetic testing. Imaging can be predictive. So if you had a patient with all these symptoms and you also had a head CT for whatever reason, and you saw a larger sized lateral ventricles, that you could just add in to what you suspect for Huntington's disease, but it is not used to diagnose Huntington's disease. It's just something that you happen to see. And like I said, the abnormality would be increased size of the lateral ventricles. The better term for it would be an increased bicaudate diameter, because you're not getting it's not that your lateral ventricles are getting bigger like you would have if you had increased cerebral spinal fluid or something of that nature. But you're getting actual degradation of your caudate, and that's just indicative of the pathologic process that's going on. So here you see the control, healthy patient, and then patient with Huntington's disease. They've got these bigger ventricles, but it's just because their caudate is deteriorated. This is the caudate right here. You also note that there's some cortical atrophy, and that you can tell just because you've got deeper gyri. These fissures are a lot more pronounced. And then here's a MRI.